Quit and reopen. I'll be right back.
Perfect. Thank you. And everybody that logs on, please mute until Dr. Fowler is done. Oh, where'd he go?
Did you kick out our speaker?
He said he had to change his settings.
Oh, okay. Somebody was listening. At least one person was listening.
I made a Sammy sandwich. Got shocked. Is that okay? Got shocked asked me what I'm eating for dinner.
All right. Can everyone hear me?
Yes.
Great. You can see my screen?
Yes.
All right. Well, thanks for the opportunity. If I get excited and start talking nonsense or too fast, let me know. This is obviously one of my kind of passions is ultrasound, and in particular for carpal tunnel. And then, as I was just mentioning, I kind of started using it for more and more things after that. So I guess kind of the framework for that, this whole talk is, should we as hand surgeons be ordering electrodiagnostic studies? So, a combination of EMG and nerve conduction studies. When I present this stuff nationally, regionally, or talk to my partners, I think there's a lot of different reasons why people order it. I think a big one, unfortunately, in Pennsylvania, which is one of the worst malpractice states in the country, is medical legally. That, if you do surgery on someone and they don't get better, and then later on you get a nerve study that looks pretty normal, you don't know, was it abnormal before? Was it not abnormal and you operated them anyway? And so I think from a medical legal standpoint, a lot of people want to get it just to have some objective baseline data. At least in my world, workers' compensation just will not approve carpal tunnel surgery unless there's nerve conduction studies. And some insurances, in particular, our Medicaid insurance companies, really want nerve studies prior to treatment. I've even kind of argued with the peer-to-peer people. I said, I'll send you some of my articles showing that ultrasound is just as good. And they just, stone face, no, we got to get the nerve studies. And they always come back positive. I think there are relatively rare cases where there is an unclear diagnosis, that the symptoms don't make a lot of sense. They can have some vague hand pain, numbness, not really the right distribution. They may be a bit of a squirrely patient. And so I think there potentially are times where it is nice to get the nerve study to see what's actually going on and get something objective in the right patient population. I think that for most hand surgeons, those are actually pretty rare situations. And I think most of us have been doing this for a little while. We probably can diagnose carpal tunnel without any studies, maybe just history of physical exam, the overwhelming majority of the time. My senior partner, Bob Goitz, who's been hearing my talks for 10 years now and still gets nerve studies in every single patient, he always says he likes to have that baseline. Kind of like I was talking about the medical legal world. He really likes to know that they were at this, just remotely, say 6 before surgery. Now it's 4.8, which is still abnormal, but it's better. And he'd say, okay, hands off, I'm not going to do anything else. A lot of people, that's just what they've always done. That's how they were trained. We always kind of talk about confirming the diagnosis, but again, I think that that's probably not necessary in most cases. And isn't that what the guidelines say we're supposed to do? Which is kind of a segue to my next slide here. So Jessica Billing and Erica Sears out of Michigan published a study in Journal of Hand Surgery. And in 2016, the Academy, through the clinical practice guidelines, changed its stance on nerve studies. A prior one, I think it was from 2009 or 2010, said that in anyone you're considering carpal tunnel surgery, you should get nerve conduction studies in that group of patients. And then in 2016, they changed it to nerve studies can be considered for all patients undergoing carpal tunnel, but rather support that carpal tunnel can be diagnosed through history of physical exam, and in particular, things like the CTS-6. You can see the table on the right side of the screen asking ASSH managers how often they order nerve studies. And you can see that the overwhelming majority, either always, usually, or about half the time, order nerve studies. I am kind of in that far right bar, almost never order nerve studies for carpal tunnel syndrome. And then when you really look at the paper, I found this kind of interesting / concerning / unbelievable in some ways, that only 38%, so 2/3 of our ASSH membership, did not think that the clinical practice guidelines were appropriate. And 40%, they didn't even know what it said. So we've got these kind of national recommendations on diagnostic studies for carpal tunnel, and many ASSH members just don't believe them, use them, don't even know what they say. And again, I think the lead into this, we're talking about what is the ideal test for carpal tunnel syndrome, and what would that even mean? One of the challenges is, when you think about the definition of a syndrome, is that it's a group or a constellation of signs and symptoms that when they occur together, they characterize that particular abnormality or condition. And syndromes in general are not defined by one single sign or symptom. So the opposite is anemia. If you get a H&H and your hemoglobin is low, that is the definition of anemia. And it's not a syndrome, it's a single definition. And that's the problem with carpal tunnel. It's usually not just one thing. Is it just numbness? Is it just this? Is it just that? And so that's why having a single test that defines it is really challenging. I wrote this kind of purposely inflammatory editorial in the journal Orthopedics back in 2017, and actually had to respond to 3 different letters to the editor from mostly PM&R physicians who were really angry about it. And one of the things I kind of brought up in these editorial in letters to the editor was that there's kind of this dogma around nerve studies that they're really good and really accurate and they should be used for people. I think the problem is that there's actually a relatively high rate of false positives and false negatives, which I'll show you in the next couple slides. They are relatively costly, although that reimbursement has come down a fair amount from Medicare. They can be painful. I'm not sure if anybody in the audience has actually had one. When I was a fellow 11 years ago, we kind of all just got the nerve conduction part. We didn't do the EMG portion. And, it wasn't really bad, but I'm sure you've all had patients come back to the clinic who are, in tears because they're so upset about them getting shocked multiple times. And as I'll show later too, they're relatively inefficient. Now, some practices have a setup where the nerve study person is right in the office, you send them down the hall, they come right back. But a lot of practices like my own, I have to send them to a different physician on a different day. They have to get the test done, they have to come back. And sometimes people get kind of lost in the shuffle. Isham Atroshi, who's an orthopedic hand surgeon from Sweden, back in 1999 sent out 3,000 surveys to the Swedish population. And they got the best response rate I've ever seen. 2,466 out of 3,000 actually responded. I think most of us have done these surveys. If you get like a 15% response rate, you're psyched out of your mind. They got a 70% response rate. And in that survey, which was pretty basic, 14% of all people surveyed reported numbness and tingling in their median nerve distribution. And he was able to talk 287 of those symptomatic patients into coming in to see him in the office for an exam. And here was kind of the breakdown. And so again, this is an orthopedic hand surgeon saying that of those 262 people that came back, they had an exam and nerve studies. And in the clinically certain group, he was willing to bet the farm that these people had carpal tunnel. 28 of those 94 had normal nerve studies. And then if you look at the other group, there were 125 subjects who on that survey reported no symptoms at all, like nothing. Their CTS6 score was 0, basically. They don't have it. He brought them in for an exam in nerve studies. You can see in this group that 23 of those, so 18%, who again had no clinical signs and symptoms of carpal tunnel at all, they had positive nerve studies. So here's kind of the summary slide. So in this group, big population-based study, there was a 30% false negative rate for nerve studies and an 18% false positive rate. So nerve studies missed the diagnosis in almost a quarter of the people that they tested. And this is like one of these mind-blowing things that, again, we kind of assume this dogma in medicine, nerve studies, they're really accurate. They're great for diagnosing carpal tunnel syndrome or ruling it out. When it's missing in the diagnosis in 25% of the patients, that's really not good. The other kind of question is, do nerve studies predict outcomes? So this is a paper I like to quote a lot out of Brown. Keith Locke, who was the main author, the lead author, but Arnold Peter Weiss was the senior author. So they looked at just their outcomes after open carpal tunnel release. And this is back, I think it was 1999 when it was published. They had 99 hands that had positive pre-op nerve studies, 27 with negative pre-op nerve studies, but must have the clinical symptoms they operated on anyway, and 101 hands that didn't get nerve studies on at all. And you can see that their resolution rate of their symptom, numbness, tingling, in all 3 groups was exactly the same. So this one kind of said, I think the conclusion even stated, why are we getting nerve studies when it doesn't predict outcomes at all? And I kind of put table 3 in there. It's always the other stuff that predicts it. So you can see that workers' compensation patients had a poor outcome 13% of the time compared to only 3% in non-workers' comp patients. So some of those secondary gain issues are always challenging. One of my good friends, Asif Ilyas from Rothman Clinic, kind of did a relatively similar study where they looked at 256 hands that had nerve studies that confirmed carpal tunnel, and they broke it down into mild, moderate, and severe. And you can see some of those breakdowns on the right-hand side over there. And all groups, whether they had mild, moderate, or severe, they improved after surgery, and there was no difference in those groups in outcomes. So, kind of, again, one of the things, get nerve studies, because if you have more severe carpal tunnel, we can really lay crepe and tell people, hey, you might not get better, you might take longer. But also study here kind of said, actually, almost everybody improves, and severity maybe doesn't predict outcomes as much. This is pulled from the American Association of Electrodiagnostic and Neuromuscular Medicine, the AANEM. And this is kind of like the main group of the nerve study people. And I pull this out here because look at all these different tests. And they kind of report these amazing pooled specificities and sensitivities. But when it comes down to it, a lot of that doesn't really pan out in the real world. And kind of the other problem is when you start testing so many different tests, you're almost bound to find one is positive just randomly. You know, what's the error rate in these tests? So I just kind of put in words what I just said there. If you need 10 different tests to make a diagnosis, where you're missing something. And I think this is the something. So here's, ultrasound of the wrist. You can see the radial artery, and I'm kind of outlining the median nerve, which is the top of the screen in that honeycomb. Now we tend to measure just inside the hyperechoic epineurium, and then the computer calculates a cross-sectional area for us. The more modern machines do it really easily, and they have these trace functions. This was kind of done with an ellipse function where it makes it bigger and smaller. In the other old days, you also had to kind of measure the A-axis and B-axis, and then do a formula to get it. But now the computers do it for you. So one of the very first studies that looked at this was out of the radiology literature in 1992. Wolfgang Buchberger was basically just trying to show that ultrasound was an accurate way to measure the nerve. So they used MRI as their kind of reference standard. They looked at 20 patients with nerve study confirmed carpal tunnel, which we just spent all this time saying nerve studies kind of suck, but still we'd like to confirm it based on something for some of these research studies, and 28 normal controls. These patients had both MRI and ultrasound. And if you look at the normal controls, their median nerve cross-section area at the carpal tunnel inlet, which we define as the level of the pisiform, was 8. And in the carpal tunnel patients, it was 14.5. And the really important thing, at least for the ultrasound world, is there was no difference between the ultrasound and MRI measurements. So this basically said that ultrasound was a valid method to measure the nerve. This is probably one of the biggest studies that was done early on, looking in 2000, Nakamichi and Tachibana out of Japan. They looked at 401 Japanese housewives, is how they were defined. So these were all women. And they looked at 201 that had carpal tunnel based on nerve tests, and then 200 that did not have it based on nerve tests and were asymptomatic. And one of the questions early on was where do we measure the nerve? I mean, you can measure it anywhere along the carpal tunnel. So you can see in the figure on the right, level 4 is kind of in the proximal forearm. Level 3 is where we just talked about at the carpal tunnel inlet at the level of the pisiform. Level 2 is like right in the center of the carpal tunnel. And level 3 is at the hook of the hamate. And so they were kind of asking, well, where is the best level? Maybe interesting, maybe not. Levels 1, 2, and 3. So in the carpal tunnel, distal and proximal carpal tunnel all actually were significant. Level 4 in the distal forearm was not. But the one that had the best sensitivity and specificity and the best kind of area of the curve was level 3, which was the level of the wrist crease. And that's the measurement I've kind of used my entire career in ultrasound. It was interesting for me going to Japan for some of the Bunnell Fellowship stuff. They weren't really as big on making these single measurements. It was much more of like a gestalt, and they measured kind of up and down. They did a lot of scanning, look at a lot of microvascular changes, but the absolute values to them weren't that important, which is so interesting because some of the main literature on carpal tunnel ultrasound came out of Japan, and they're not even doing as many measurements as I thought they would be. So there's been a number of studies, and I feel like every time I give this talk, I have to go and update the study list. So right now there's over 30 studies. I think it was 36, 37 last time I checked, comparing ultrasound and nerve studies for carpal tunnel. And it really depends on what reference standard you use. It's actually nice if you use clinical exam, but which clinical exam? I've used CTS-6 in a lot of mine. We'll talk about that soon. But one of the problems is that a lot of these studies use nerve studies as the reference standard. And we just talked about how there's a number of false positives and false negatives for nerve studies. So how can that really be the reference standard? So you make your 2x2 tables, you receive operating curves, and really what you'd like to do is optimize both sensitivity and specificity. The ideal test would just have 100% for each, but a lot of times those are competing factors. So optimizing specificity is actually better for confirmatory tests. If you remember kind of the formula for specificity, you're trying to drive down your number of false positives because you don't want to operate on somebody that doesn't actually have the disease process, because then they probably won't get better. So one of my first forays into this whole ultrasound thing was in residency. I was a resident at Temple 2007 to 2012. So you can see this got published in 2011. And we ran a resident clinic supervised by the attendings. And we would see patients all the time with carpal tunnel syndrome. Remember back then, the recommendation from the clinical practice guidelines were, hey, if you think they have carpal tunnel, get a nerve test. So we'd see people in the resident clinic. We'd write them a prescription, go get nerve studies. And literally 25% of people would come back a couple months later with the nerve stuff that actually. Now, part of that's that population. It's hard for them to get medical care, and they sometimes don't do a good job on that. But just really frustrated. And so that's when I really started kind of looking into, okay, there has to be a different way. What other way can we confirm this clinical diagnosis? And I kind of at that point, probably this is like 2009, 2010, kind of stumbled onto ultrasound as potentially one of those reasons. So at the time, I just told you in the last slide or 2 slides ago, 30 studies comparing ultrasound and nerve studies. We found 19 back in 2011. So there's definitely been an increase over the years for this. And the reference standard matters a lot. So I just talked about clinical diagnosis, nerve studies are kind of a blend of the two. And you can see that when you use clinical diagnosis as the reference standard, carpal tunnel ultrasound actually has a very high specificity. I mean, you would take a specificity of 93% any day of the week. And I think the sensitivity of 77 is actually pretty reasonable looking at some of those studies. I was super lucky in my fellowship when I came to Pittsburgh that I trained with Bill Hagberg, Joe Imbruglia, Glenn Buterbaugh, and they actually had an ultrasound machine in their office, which, you got to think back to 2012 was pretty impressive to actually have that. The other nice thing is they were a very busy private practice, and they didn't really need the fellows to see the patients themselves. Saw them, we talked to them about the patients and learned a lot, but we were kind of just there to learn. And so for literally 2 months when I was on Joe Imbriglia's service, I ultrasounded every single patient that came through the door. And anybody that had carpal tunnel, I did the ultrasound, they sent them down the hall, and they did a nerve study right there in the office. And so we used the cross-section area of 10 as positive diagnosis for carpal tunnel. You can see the cutoffs for the distal motor latency, distal sensor latency. Now, the other part with all these studies, that's very debatable. Different labs use different values. Some people use 4, some people use 2.5. It's all over the place.
He can restart it.
It'll come back on. Keep going, John.
Okay. And then the CTS6 was calculated by a nurse. And so you can see the CTS6, and these are really kind of the classic signs of carpal tunnel syndrome. I think the only thing I might do is kind of replace the positive Phelan test with maybe like a Durkin's compression test, but these are all things that we use. One of the other kind of bad things about it is thenar atrophy weakness is a very late sign. Like you probably only get that late in the disease process. But so Brent Graham developed this. It's based on Bayesian math. And if you have a score of 12 or greater, that gives you about an 85% chance of having carpal tunnel based on the opinion of an expert panel. So we did all the information, or did all the studies, and you can see some of the data that comes out here. So people that had a positive CTS6, their mean cross-section area was 12.7, which anything over 10 counts, and anything they had negative CTS6, it was about 8, which is, it was less than. And then kind of the interesting things, when you look over here to the right side, look at the sensitivity and specificity. So the sensitivity is the same, and you can see that ultrasound actually wins. It had a better specificity than nerve studies in a prospective cohort. And I'm very proud of this, doing this as a fellow, because it's still one of the largest prospective series in the literature looking at ultrasound for carpal tunnel. And this got published in JBJS a while back. So if you use CTS6 as the reference standard, I think the clinical exam is probably the better one. Ultrasound is accurate in 89%, nerve study is accurate in 83%. That difference wasn't statistically significant. I think if we had more patients, it probably would have eventually become that. And even if you just want to use nerve studies as the reference standard, I think ultrasound actually performed very well overall. So you can see that was what, 85 patients, I think we said. I had so much fun doing that when I got into practice, I just started getting this like large database of patients. So then we did it again in 402 hands instead of 85. Did the same thing, CTS6, ultrasound, and nerve studies. And you can see, I thought I highlighted this, but if I kind of point down here in the positive CTS6 group, you can see their mean or mean or average cross-section area was 11.6 versus 9.8 in the negative group. Then the second part of it, looking at the sensitivity and specificity, they didn't really perform as well as they did in the other study. And it's kind of hard to know why. That your patient population makes such a big difference. So that very established practice with Joe Imbruglia and Glenn Buterbaugh, I think that probably artificially raised it because they were getting referrals of people that had it, or maybe they were just really good diagnosticians. Maybe they just didn't send anybody for nerve studies they didn't think really had it. It's hard to know. It's all speculation. But one of the things I want to point out is the specificity. Look at the specificity for electrodiagnostic testing. Like 27% is like atrocious. I mean, it's basically they have so many false positives in that group that I don't think you can trust the data. And so I think ultrasound ends up being a little more balanced in this kind of large group of patients. The other thing I get when I present this nationally is, yeah, but. I get a lot of yeah, buts. Yeah, but isn't ultrasound operator dependent? And so I love it when I get questions at these conferences, because then I go back to work and I'm tested. So Kevin Cruz is one of my fellows. He's down in Texas right now doing a lot of ultrasound for shoulders, actually. David Hirsch is a hand surgeon that works for Rothman down in Florida now. And so we, at morning conference, we used to do it in person. We're at home now. We basically went in, we grabbed the hand fellows one at a time, brought them out to a table, and then me, David, and Kevin ultrasounded them independently. We kind of recorded our values on a little piece of paper. We sent them back. We brought them all back 2 weeks later in a different order and everything. We did it again. And you can see that we actually had near perfect agreement between me and David Hirsch, who had literally never picked up an ultrasound transducer before we did the study. We had very good agreement between me and Kevin and Kevin. By not measuring as well. But it is operator dependent, but there's a pretty quick learning curve. And well, then the question became, well, fine, what's the learning curve? Like, how long does it take? So then we went to the cadaver lab and we took our interns. So again, people have really never picked up an ultrasound. Measure the nerve. And that's all we gave them right there. We just kind of gave them a little piece of paper. We said, okay, measure the nerve. We didn't really show them where it was. Then after they measured the nerve, we gave them a little like PowerPoint teaching session, like 3 minutes. We kind of showed them the anatomy, showed them what the nerve looked like, you know, did all this stuff, and then sent them back. At the time, so they missed the boat. They almost always measured the FCR or the palmaris, thinking that was the nerve, and it wasn't. After that literally 3-minute teaching session, they got the correct structure 97% of the time. So I think all of you are far enough along in your training that you're going to be better. The correct structure every time. So that's part of like, are you measuring the right thing? I mean, that's important. And then the second part of it is, well, I mean, how close are you getting to the quote unquote real measurement? Now that's a little bit tricky because that was my measurement, which I'm not saying was actually the right measurement, but that's just the one that I had. I could have been off myself. So before instruction, and I find this part really interesting, you may not, but if they actually measured the correct structure, they did. And it went up a little bit to about 3/4. So that's the question, like 1 millimeter squared can mean a lot. And so what if 10's the cutoff and you're off by 1 millimeter squared? That means you're measuring anywhere between 9 and 11. And that's kind of problematic. You could have, definitely don't have carpal tunnel. Kind of tricky. I was, talking about that Bookberger study kind of back in 1992, and,